Welcome to new Retina Radio series called International Perspectives. I am Patricio Schlottmann from Organización Médica de Investigación in Buenos Aires, Argentina. On this episode of International Perspectives, we will explore practice patterns and opinions regarding diabetic macular edema. On this episode, I am joined by two guests. Catherine Creuzot-Garcher from the University Hospital at Dijon, France. Hello, Catherine.
Hello. Hello, Patricio.
And by Adnan Tufail from Moorfields Eye Hospital in London, United Kingdom. Hello, Adnan.
Hi there, Patricio.
And I would like to start the discussion regarding treatment selection. For patients with wet AMD, we have only one option for treating these patients, which is using anti-VEGF drugs. But for patients with diabetic macular edema, we have an option of either using the well-known laser, we can use the steroids, or we can use the anti-VEGF. Despite having a menu with three options, most places worldwide would choose to treat patients with anti-VEGF overall, despite some smaller populations being treated with possibly other options. And this is usually because when we look at the safety profile and efficacy profile of the anti-VEGF, they have a great range of patients gaining a lot of vision and a very small proportion of patients losing vision. Is this something that you agree with, Catherine?
Yes, usually we consider patient characteristics before selecting one treatment or another one, but in most cases, anti-VEGF remains the first line treatment to treat DME patients. We can have some alternative, especially for pseudophakic patients where steroid can be used, but in most cases, anti-VEGF remains the first line treatment.
Is the same situation, Adnan, in London?
Yes, it's very similar. We are funded nationally and we have national guidance that will prefer anti-VEGF for DME, but with a limitation of greater than 400 microns on initiation of anti-VEGF if it's funded by the NHS. In the private sector, people may well usually use anti-VEGF as first line for center involving macular edema with less than 400 microns. And as in France, in pseudophakic patients, we have the option of a corticosteroid as well.
And what would be having an option of patients being treated with other forms of treatment rather than anti-VEGF? What would be your selection criteria? For example, you see a patient that is pseudophakic and has never had any response regarding IOP to steroids. And you see the patient for the first time with macular edema above 400 microns. Adnan, how would you make your decision on that patient?
So we would make the decision based on the pseudophakic, also look at the retinopathy grade, so have an understanding of that, whether or not they responded to a particular intervention in the fellow eye and how they responded, their overall level of control and potential for compliance in the future. Because either intervention would not completely protect you against progressing to proliferative disease. If it was greater than 400 microns and all things being equal, given the better side effect profile of anti-VEGF in terms of IOP, we would still go for anti-VEGF as the initial option.
Excellent. And is it the same in France, Catherine?
The main interest of corticosteroids is to limit, to have a lower number of injections. It is true, especially after the second one, because at the beginning you need to check the IOP, you need to check the efficacy. So after the second injection of corticosteroids, then you can limit the number of visits. So for a patient who is a little bit reluctant for coming very often, corticosteroid can be an interesting option.
One of the things that Adnan mentioned is that we need to take into consideration the diabetic retinopathy status of the patient. And that probably is, and correct me if I'm wrong, Adnan, this is because with anti-VEGF, you may see a regression of diabetic retinopathy that you don't see that much with the use of steroids. Is that, Catherine, something that you take into account when making a decision?
Yes, of course, if you have a diabetic retinopathy, then probably anti-VEGF is one more argument to use anti-VEGF. But I am still not confident to consider anti-VEGF as a definitive treatment for diabetic retinopathy. And it is just a way to wait for laser, for instance, if you have a proliferative diabetic retinopathy.
That's a very good point. That's a very good point. And Adnan wants to make a comment. Please go ahead, Adnan.
Yes, so I completely agree with Catherine. I think initially when we had anti-VEGF, there was a regression in classic ETDRS retinopathy grade, but it doesn't equate to resolving capillary closure. And increasingly studies from France and elsewhere have shown that it does not reverse the area of capillary closure. And work that others and we presented at ARVO this year showed the progression rate, even with anti-VEGF, is significant over time in real-world delivery of therapy, and it's dependent on a number of factors, including baseline ETDRS retinopathy grade. So it's useful in that it reduces the risk of progression. But in real world, we don't give it every month. And in fact, even in RISE and RIDE, where patients were given every month, about 10% eventually became proliferative. So you need to make sure you still check the peripheral retina when you start these patients on treatment. And as Catherine says, in the UK, if they do become proliferative, our choice would still be, if they're high-risk proliferative, to go for definitive scatter laser.
Certainly, yeah. We see that these patients have a change in their color photographs, but when we look at the FAs, we don't see that much of a change. So it's a magic for the short term, but in the long term, patients need to be treated accordingly. And certainly we will need in the future a better classification, not based on just color photographs, right?
I think the classification is adequate in treatment anti-VEGF naive patients. The problem now is that classification is not good in patients with anti-VEGF.
Certainly, certainly. It's not good for establishing a new classification of risk for that patient, which is what we use with this classification. And Adnan, you mentioned something that you have a limit probably set by the NICE guidelines, setting a limit in the thickness of the OCT for the patient to be treated with anti-VEGF. Is there a limit on visual acuity as well?
No, there's no limit on visual acuity, but there is a limit on thickness. However, we know from more recent DRCR-NET studies on treating patients with good vision that it's reasonable to consider waiting if the patient's got 6/9 or better vision as an option. But again, you would temper that in other factors in the eye and how they responded to treatment in their fellow eye if had DME as well.
If it was totally up to you and the NICE guidelines were to be rewritten by your criteria, would you set up a limit on visual acuity or thickness of OCT to start treatment? Do you think this may delay the start of treatment in some patients and that creates some damage in the retina?
So we know that delayed arms in randomized controlled trials don't quite catch up as much. So there is if you want to optimize the treatment for the patient in front of you, it would be nice not to have a limit, but to discuss the options with the patient and allow the physician and the patient to come to the right decision based on a whole number of other factors. If you're going to ration treatment to some extent, which is what NICE are doing, then it's not a completely unreasonable way of rationing it, even though one can argue it's a post-hoc analysis of data and how they've rationed the treatment.
Catherine, do you have similar guidelines or limitations to start treatment with a patient regarding visual acuity or thickness of the OCT?
Well, in theory, we should wait for visual loss, but in fact, we are in a very lucky country, so we can treat all patients if we want to treat the patients. But we know that if we treat the patient too late, then the visual gain is probably good because the visual acuity is low, but the final visual acuity remains low. So we know that if we want to have the best final visual acuity as possible, we need to treat the patient earlier. That is to say, with a better visual acuity than before. Patient is not interested in the visual gain. He is interested in his final visual acuity. So, of course, we do not treat a patient with an increased retinal thickness and visual acuity at 20/20. Of course not. But probably we can treat patient earlier than before.
So if we look at these, there are a couple of ranibizumab studies like the RESTORE and the RIDE and RISE. And these studies, they had one of the arms without treatment for a while, and then they started treatment. The RESTORE was for 12 months and the RIDE and RISE was for 24 months. Of course, they received a rescue laser if needed. But these patients, this is the population that did not catch up or did not gain vision as fast as the other group. So that would be the too late, the treatment. How long do you think it's the latest that you can treat a patient? And how much do you look into these biomarkers to make a decision? Let's say a patient tells you that the vision has been bad for 6 months, but you don't know whether the macular edema was there for longer. So do you change your way of treating a patient if you look at the OCT and you see some changes in the ellipsoid or any other biomarkers that will help you in make a better choice for the treatment decision for this patient? Catherine, for example?
Well, of course, we analyze the OCT and the aspect of the retina. If you have a very huge macular edema, and in fact, you have almost no retina, you have only bleps and no more retina, the risk is to have a very low visual recovery. But usually we try. It is very difficult to say that the beginning of a macular edema was at that time, because it can be longer. So we treat the patient at least for 3 to 5 injections, and we analyze the visual acuity. If we have no visual recovery, then we stop the treatment, but we try.
Okay, and Adnan, what's the situation in London?
So, as I said, we're slightly limited, but again, rather like in France, you don't make assumptions that a patient fully understands how long they've been symptomatic for, especially if it's their worst eye. And so, given the data, in an ideal world, I would like to initiate therapy for a symptomatic eye, independent of the thickness of central retinal thickness level.
Excellent. It is interesting that the NICE guidelines are based on thickness as the only biomarker, but they don't look at any other qualitative characteristic of the OCT.
Yeah, that was based on their sub-analysis of the original pivotal trials, and was clearly a way of looking at a subgroup which was most cost-effective. It's not to say the other groups aren't cost-effective, but it was the group that was most cost-effective. And so that's the group that gets it automatically for an unlimited amount on the NHS. It's not that you can't give it, but it wouldn't be automatically funded. Whereas for steroids, ironically, there is no limit for thickness, but they do need to be pseudophakic.
So they came up with this decision based on the analysis of the pivotal trials. Did they put a limit on the HbA1c of the patients as the pivotal trial? Some of them use 10, some of them use 12, or you can treat at any level of A1c?
So it's not limited to that.
Is it the same in France, Catherine?
Same in France, yeah.
So you can treat a patient. So because I'm asking this question because you work in London and in Dijon in France, and those are very special places where the government covers, the social system covers the medication. But worldwide, in many places, they have restrictions regarding the A1C, for example, and they have to wait only until the A1C falls under a limit to start getting the treatment for the patients. And I think there's enough evidence to go against this, saying at any level of A1C, you will have a response, right?
Yes, true. Because if you are waiting for the A1C to become normal, many patients are not treated because they are not able to reach this threshold. I don't know what kind of threshold, but most patients have a A1C around 8, and however, they can have good visual acuity. But it means that you should not delay the treatment, but in the same time, you should ask the patient to take care of the blood pressure, of the A1C, of the lipidemia, of the lipids, and so on. So I think it's not fair to delay the treatment for this reason.
Adnan?
So with regards not starting anti-VEGF at high HbA1cs, that's a literal interpretation of the original pivotal trials. So it's understandable why some countries have done that as a way of rationing therapy. There are some counter arguments to that. So the argument for it is a patient's more likely to be motivated to control their diabetes once they've been limited to getting a therapy to improve their vision. The counter to that is that we've known for a very long time that if you suddenly improve your control, you actually get a transient worsening of your retinopathy status as you actually have reduced blood flow. And this is work done in the 90s in the Hammersmith Hospital and in other places. You could rapidly control your blood pressure and renal function, which may well improve macular edema, but actually a sudden improvement in control of the HbA1c may be counterproductive to the short-term care of your patient. So I don't think it is an ideal strategy. And I think there have been sub-analysis to show that patients, even with poor HbA1cs in the real world, do respond well.
Thank you for that, Adnan. So now let's move into another topic. We know that under-treatment limits the potential for visual acuity gain in patients with DME. And Catherine made it clear that in France, they have almost no restrictions to treat the patients. And you have a restriction to enter for some of the patients, Adnan. But then your second, third, fourth, and fifth injections will be run by a separate set of rules. Do you have any of you two have a fixed treatment regimen that is imposed by the system, or you can treat your patients with whichever regimen you would like to? Catherine?
No, we can use the regimen we select, and it depends on the patient. We are more and more comfortable with a treat and extend regimen to avoid undertreatment. It is easier for the patient, especially if you can perform the injection the same day as a visit, to limit the trip for the patient. Diabetic patients are usually working age population. So if you can decrease the burden for coming in the department of ophthalmology, is better to increase the compliance.
But you still run a separate or a different regimen for some. It's PRN, treat and extend for the majority, but some of them may be using other regimens.
Yes, in some cases we can use PRN.
Okay, and you treat and extend, extending up to 16 weeks, 20 weeks?
Usually it's not exactly the same as in AMD, where we stick to injection every 12 or 16 weeks for 1 to 2 years when reaching this threshold. In DME, when we reach 3 months, 12 weeks, usually we try to stop the treatment, but because sometimes it means that we have solved the problem.
Excellent. And Adnan, is it the same situation in Moorfields?
So there is a guidance from NICE, but there's quite a lot of flexibility. So NICE in the original ranibizumab guidance was treat to stability, visual stability, and then PRN or extend out the treatment. And for Eylea, again, it mimicked the original product label from EMA at the time, which was 6 injections and then 2 monthly up to a year. And then you could either PRN or treat and extend out after that. So by and large, we treat until we get what we feel is an anatomic response, and then we extend it out. Because there's sometimes a bit of a lag for visual acuity between that and anatomic response.
Okay, and you would be probably extending by 4 and 4 weeks, or you go 2 by 2? and what is the maximum time of extension?
So typically it's about 2-week intervals. And again, when we get out to 3 months, we would then, very similar to France, consider the option of stopping the therapy and observing.
Okay, so now we have discussed things that we probably used to do. When do we start the treatment? What is the limit for waiting for a patient, and the treatment regimen that we use, and the treatments that we prefer for managing patients with DME. But lately, over the past almost 2 years, COVID has changed that situation probably dramatically, with lockdowns and restrictions for patients to move around, restrictions in the hospital services, less amount of doctors available to see the patient. How has these impacted on your diabetic patients? As Catherine said, diabetic macular edema is a condition that behaves completely different from wet AMD. So it's a little bit more permissive regarding extending times in between injections. But, you know, the COVID was a long period of time of restrictions. Has this impacted much into your population of patients, Catherine?
Well, the recommendation from the French Society was to delay DME patients and to treat only and to keep the treatment only for AMD patient. In our department, it was easier to keep patient under treatment because we do not select a patient according to their disease. So we apply the same interval as before, and the patient come to have his injection, but without any visual acuity measurement and without any OCT that was performed. So we apply the same regimen, the same interval for the lockdown period, and then we come back to our usual practice with visual acuity and OCT when lockdown was finished. And we noticed that some did not come, but most of them come.
Okay, and Adnan, what was the situation at Moorfields?
I think we were quite similar again to France in the initial first wave, where we were recommended to allow safe spacing for the neovascular AMD patients to continue treating as standard of care for neovascular AMD, but delay patients who are not urgent, i.e. didn't have coexisting proliferative disease, who just needed anti-VEGF, until the end of the first wave. We also then virtualized some of their management for the diabetic patients, where they would come in into a virtual clinic where they get a wide field picture and an OCT and a visual acuity. We're now back to normal care. However, similarly, many patients who are diabetic were initially afraid to come back, so there were a lot of DNAs. And we have picked up a lot of patients who come back with, proliferative disease. And so we had a bit of a rush of rubiotic and proliferative patients that we had to manage. And also they were neglecting their care. So a lot of them were at home and overeating and overdrinking in the lockdown. So it was quite an interest. Some of them actually had more exercise. Some of them got a lot worse. A bit like us, I suspect.
Yeah, I think it was the same situation for everybody. So doctors included, as you mentioned. So any of these things that you have done during the pandemic, any of these tricks that you have to resort to keep a good treatment of your patients, like the virtual clinics that you mentioned, is there anything that you're keeping for the aftermath of the pandemic? Is there anything that you say, this is something that we should have been doing, long before? Adnan?
So we already have a very good national screening program for diabetic retinopathy, where once they get past a certain threshold, they get referred into hospitalized services. But we know that even if you have moderate non-proliferative and minimal diabetic macular edema that's non-center involving, the risk of visual loss is still very low. And actually, those patients we are now keeping into a virtual setup, which is wide field imaging and OCT and visual acuity, but under the hospital care, and then only bring them into a face-to-face clinic if the patient requests it, or if there is progression where they would need active treatment. So that's freed up some clinic space in the system.
Catherine, anything that you kept from the pandemic strategies to your day-to-day practice these days?
Yes, probably to avoid visual acuity measurement at each visit. And we try to do it regularly, but not at each visit. And just to base our treatment, not to treat or not to treat only on the OCT analysis, and to regularly measure the visual acuity. And also to ask for the patient to, it is funny, but to come alone and not with all the family around the patient. And it is very, very quiet in the consultation now.
Thank you. Thank you very much, Catherine. So we could be discussing all the management of patients with DME for days and days, but we need to close now. So that's it for this episode of the International Perspectives. And I would like to thank our panelists, Adnan Tufail in London and Catherine Creuzot-Garcher in Dijon, France. Please be sure to subscribe to New Retina Radio on whatever podcast platform you use, and we will have more from this series coming in the near future. I am Patricio Schlottmann from Buenos Aires, Argentina, and thank you very much for listening.